The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Today is Wednesday, May 27th, 2020, and it is the webinar Wednesday. Welcome to our ASC educational sessions. Today, we have our guest speaker, Dr. Zubair Baloch, from Philadelphia, Pennsylvania, and I'll give you a brief introduction before I let him take over the virtual podium. He's going to be talking about the algorithmic approach to everyday salivary gland cytology and touching on the Milan system. Dr. Baloch is very well known to the cytology field. He received his medical degree from Liaquat Medical University in Hyderabad, Sindh, Pakistan. He joined pathology residency in Hanuman University Hospital, and then he did his fellowship in surgical pathology in Memorial Sloan Kettering Cancer Center, followed by cytopathology fellowship at University of Pennsylvania in Philadelphia under the mentorship of Dr. Prabhav Gupta, whom you also know, and hopefully he's listening to you today also. Dr. Baloch is a professor in the Department of Pathology and Laboratory Medicine at UPenn Medical Center. Now, if I went into all his presentations and publications, I think I'll fill up the whole hour. I won't do that, but I'll let you know that he was one of the co-editors of the Milan system, as well as being involved with the thyroid Bethesda system. And he also served on the international panel recommending the renaming of the encapsulated follicular variant of papillary thyroid carcinoma, the NIFP. So if you get ever upset about NIFPs, you have Dr. Baloch to blame. Joking aside, he's a wonderful pathologist, and he's also on the executive board of the American Society of Cytopathology and a wonderful human being. Here you go, Zubair. All yours.
Thank you, Guliz. It is wonderful to join a broadcast which is spearheaded by ASC leadership. It's always wonderful to work to do stuff for ASC because ASC is our own society, and it's a society which has the best educational and the social gatherings. So with further ado, I'm going to start. I have nothing to disclose. I wish I did at this point in my life, but so far nothing. I do want to start with this slide because it is such a difficult time for many of us and our families, and it's due to what surrounds us, and we are basically at home most of the time or at work. The social gatherings have stopped, and it has really made us realize how good our lives are and what we have or what we do not have, and basically what we have. So if we are blessed, then I think it's good to count our blessings, plus pass them on to our surroundings and the people we know, because I think this is the way to live. So with that blessing, I am going to start my presentation. So I'm going to just take you through some of these questions. So this is one of the questions that I'm going to start with. So just kind of check your knowledge base. And it is the name American Society of Cytology was adapted in which year? Can we start the poll, Joanne?
Yeah, I hope you're all seeing the question poll there. And the answers are 1961, 1913, 1953, 1969. And by the way, I love this question. Very nice. Right, and Joanne just shared the poll, and it looks like, well, you have a tie between 1969, 37%, followed by 1953, 35%, and then you have a 1961. So let us know what's the correct answer, Dr. Baloch.
Okay. So actually, the correct answer was number one, which was 1961. And as you can know, their first annual scientific meeting which is ASC's former name was Inter-Society Cytology Council was in 1953. And it was in 1961 in Memphis that we adopted the name American Society of Cytology. Okay, So whenever you talk about an organ system and cytology or histology, I think it's really important to know what has been done, because then it will give you a good perspective of what you're understanding now in your present and what is being predicted for the future in that field. Because it's good to be aware of your past as well as your present status and as your future. So what do we know about salivary gland lesions? And this is actually one of my favorite slides, because whatever we do is effective for our main client is the patient. So what does the patient know about the salivary gland FNA? And if they go naturally to an American Cancer Society website, which I think is most really visited by the patients, it really gives a good overview of salivary gland FNA, that it is helpful, but it also points out that in some cases you may not get the definite answer from salivary gland FNA, which we all know holds true for some of these lesions. So this is all has been in the textbooks and in the literature, what a salivary gland FNA can do. It's basically differentiates some of the benign diseases from the malignant diseases, inflammatory from neoplastic, and even in cases of infection and metastasis, it can be helpful. What I think is also should be known that the salivary gland FNA is very good for the diagnosis of a squamous cell carcinoma, because the parotid gland site has lymph nodes around it, and those lymph nodes can have metastasis from squamous cell carcinoma coming from other side, especially from the skull, and some of the skin squamous cell carcinomas can metastasize to parotid gland and can be mistaken for primary squamous differentiating lesions in the salivary gland. So at least you can make the diagnosis of malignancy. Now, if you're doing FNAs yourself, it's good to know what are the complications of an FNA, because from a patient's point of view, it's very important to know what can go wrong with a salivary gland FNA. The needles we use nowadays and the methods we use basically is negligible. But if somebody really points out to you what can happen, you can list these, which is very, very uncommon. Interestingly, the cystic lesions of the salivary gland are parotid, especially wharton, has a chances of getting infected. So cystic lesions can get infected, but if you're following all the good protocols, nothing will happen to the patient. Now let's look at what has been in the literature about salivary gland FNA. The literature will read from A to Z all the lesions you can diagnose on cytology. But I have listed the most common ones on the top for non-neoplastic, for benign and malignant, that you are going to see in your practice. But this list is, I can add so much, and I can have the entire presentations on what you can diagnose on salivary gland FNA. But need to know that some of these common lesions we can effectively diagnose or classify in appropriate categories on salivary gland FNAs. Now, what is our gold standard? Let's look at our gold standard, which is always is for cytology, the histologic follow-up. Now, if you look at the gold standard, it has changed, or it is constantly changing or being revamped. From even 1972, you see the list on the left, how small that was. And now let's look at the 2017. And I bet if you even make this list now, you're going to add many of these lesions now. Now, what is the salivary gland tumor diagnostic paradigms for histology, which is our gold standard? You diagnose malignancy based upon invasion, which can be gross or microscopic, but there are benign neoplasms or benign lesions where invasion is absent, but they can show multinodular and irregular growth, capsular violation, and even there are some malignant lesions which may not show invasion microscopically. So there is even in search path, there are problems sometimes or diagnostic difficulties in diagnosing these tumors, depending upon how really proficient you are in reading these slides. Cytologic features of malignancy, pleomorphism, mitosis, and necrosis. But some malignant tumors may not show cytologic features of malignancy. They may consist of only monotonous basaloid cells, even if they are high-risk tumor. such as adenoid cystic carcinoma. That's why adenoid cystic carcinoma, some of these cases may be moved to being called as only basaloid neoplasm with differentiation. Now, benign tumors can show extreme cytologic atypia, such as pleomorphic adenoma, which is the most common tumor you are going to see on a salivary gland FNA. They can have increased cellularity, mitosis, even post-FNA tumor necrosis. And by the way, I just want to say that it's good if you are doing the FNA or you're on site for the FNA and you see atypical cells in a case which you're going to call pleomorphic adenoma, ask if that has been biopsied before, because I have seen atypical looking cells in prior FNA cases of pleomorphic adenoma. So this paradigm is also not so clear-cut and can pose diagnostic problems even on histologic follow-up. Furthermore, we know that the FNA of the salivary gland tumors can be problematic because of the morphologic overlap or morphologic heterogeneity. And if you see this, this is an amazing, I love this slide where you see the luminal cells, the basal cells, mixed and myoepithelial cell origin. You can see all these tumors kind of going back and forth. So there is an overlap. Similarly, if you look at the myoepithelial cell differentiation, you see it in the benign tumors, and this can be of varying degrees. That means it can be concentrated in some areas, or some areas may not show many myoepithelial cells. And if an FNA sample is limited to one area of these tumors, somehow you can see there will be a lot of morphologic overlap between the benign as well as malignant lesions. So this is what is in the background, what we base our diagnosis on. So you can see that's why I think this is not such a clear-cut field, but as long as you know that you're classifying it on a management-based protocol, your FNAs, it's the best for the patient. Now, this leads me into the diagnostic reporting and management. And as you all know by now, the Milan system, which came out, and it has a range of the risk of malignancy for diagnostic categories. And what the beauty of Milan system is that it has a range of diagnosis, which goes from non-diagnostic to malignant. But there is this middle group, which really represents the range that we are accustomed to seeing in our everyday practice of FNA of salivary gland. So reporting in those categories is basically a management-based classification scheme, which is very good for the patient rather than benign or malignant, which really does not happen because the biology is not black and white. It is always, there are many, many gray zones. So this system that is good, and if you're not using it, please use it because it really provides, and I will tell you, the clinicians really appreciate this system. So this is just my introductory kind of slide to the Milan system. This is the cast of characters involved in the Milan system. And I found this slide, which was actually when the Milan system being devised. And here's Dr. Barkan, Dr. Esther Diana, Bill Facquin, Dr. Philip Veal, and Mark Pastrasi. And you can see this is where it all started. And here's the group photo. And, you know, the Milan system is a kind of a system which I really love about it. It's not a static system. It is more of a dynamic reporting process, which the really changes are being made. There is a lot of online presence, and it really makes you familiar with how to use this system and what it is good for. So this is another slide. I love internet actually, and looking at stuff, and you can see how much has been done since the publication of the Milan system. So let's go to the question number 2. And this is actually a 60-year-old man who underwent FNA by palpation of a 1.5 centimeter mobile mass and left parotid gland. And this was definitely a distinct mass. So how will you classify it according to the Milan system for reporting salivary gland cytology? Joanne, can we open the poll?
Okay, I'll read the poll answers. Neoplasm, benign, non-neoplastic, non-diagnostic, and salivary gland, neoplasm of unknown malignant potential.
Okay. So there is a mass. It's an old patient, which is a 1.5 centimeter distinct mobile mass in the left parotid gland. What you got is salivary gland SNI, and here are the salivary gland SNI plus the ductal structures. So this is specimen, in light of the clinical history, will be considered as non-diagnostic because it is not representative of that 1.5 centimeter distinct mobile mass. So let's move on to the, so this kind of leads me into this, and I will tell you how many times this helps me to really go back and look at these slides. Even if at my level, this is a good reminder. And the reminder is, what is the normal salivary gland histology and cytology looks like? Now, there's two cartoons here which shows you the major salivary glands which you are going to biopsy is parotid and submandibular gland. And then there are minor salivary glands which you may also get to biopsy under radiologic guidance. And if you look at the structure of the normal salivary gland histology, there are myoepithelial cells, there are acinar cells, which are the most prominent, and then there are ductal cells, and there are intercalated ducts and the striated ducts. Now, how do they look on histology? When you took the histology picture, here is the acinus, and here the ductal structures and the vascular structures. And you can see there will be varying amounts of fat and muscular and nerve tissue around it. Now, when you biopsy this, this is what comes out on the biopsy. You can really correlate the ductal structures with the ducts. You can see how they come out. They almost appear very squamoid, a lot of cells congregated, and they actually have a beautiful layer of the myoepithelial cells kind of surrounding these ducts. And the acinar cells, which are these grape-like clusters, and basically you get an entire unit of the acinars and the ducts together in most cases. Now, this is just another example on a high power which shows you these grape-like clusters plus the ducts, which appear very squamoid structures. So this is how the normal salivary gland FNA will look like. And you will see that in most cases when the manual guided FNA missed the lesions because it was very mobile or it was small, so it's very operator and sampling dependent. You'll also see fat in the background, and sometimes you may see stripped acinar cell nuclei or few lymphocytes because there are intraparotid lymphoid collections or lymph nodes. So this is a very good benchmark to follow how the normal salivary gland will look like. Now let's go to question number 3. The question number 3 is the current name, American Society of Cytopathology, was adapted in which year? Can we open the poll?
All right. That's another question I like. Very nice. So the options are 1963, 1961, 1994, and 1970. 4 options.
Okay. So the answer is the current name of American Society of Cytopathology from Cytology was voted on during the 42nd annual scientific meeting held in 1994. And I think this is the biggest milestone in our profession where a society has embraced every single facet which deals with the practice of cytology, and every single professional person which is involved in for the society. And that's what you really should be proud of this society. Now let's move on. What are the salivary gland FNA components? And I think this is a good flow chart to remember. You have lesional cells. You also look at background. Remember, these are limited cellularity specimens. So everything counts. And when you look at the lesional cells, you have to understand whether these are epithelial cells or other type of cells. What does the background shows? And this is kind of the paradigm I'm going to follow throughout my presentation. So this is a good flow chart or a table to really kind of remember. You don't have to remember every single thing, but the cells and the background. So let's look at the pretty pictures of salivary gland tumors, pattern recognition. So you look at the architecture, and for me, architecture is very important because it really provides you a radiologic correlation. Because some of these, and I will say at our institutions, the majority of these are being done under ultrasound guidance and some deep-seated lesions under CT guidance. So the radiologic descriptions are very helpful. Whether this is a cystic lesion, it is a solid lesion, is it hypoechoic or hyperechoic, how does the borders look? And it really gives you a kind of a diagnostic paradigm which you are going to follow when you're evaluating these cytology slides. What type of cells are you seeing? Are you seeing the basement membrane or stromal type material? And what is the background? Is it mucinous? Is it cystic background with macrophages, or there are inflammatory cells or lymphocytes? So these are the things that will be very helpful in really putting it into a category. Now, this case is a 60-year-old man, and this is actually a very good case. It was a case of mine, and I always love showing this case because this is where it really made me much interested in salivary gland cytopathology. So this was a 60-year-old man. He has a history of lung adenocarcinoma, and they found this superficial left parotid mass during screening. The mass on the ultrasound was solid and lobulated with no invasive growth. And this is what it looked like. We were not on site, and all the FNA specimen was placed into a thin prep vial. So what I'm showing it to you are the two good areas of the thin prep. As you can see here, this has this really monotonous population of the cells. Most of the cells have a very dark and even chromatin pattern. And as you can see here, there is some kind of a stromal material in the background, plus running among these groups. And here are also these cells. Some of them are actually in doublets, and some of them are spindly in the background. Now, based on this specimen was called as basaloid neoplasm with a differential, and on the top of the differential was basal cell adenoma, cellular pleomorphic adenoma, but there was a notion that we cannot differentiate a basaloid malignancy, including adenoid cystic carcinoma, or basal cell adenocarcinoma was on the lower part of the list. Now, when this patient underwent surgical resection, and here are the cytology slides for reference, and here are the SearchPad slides. This case, as you can see on this power, shows you a very well circumscribed kind of lobulated structures with little pushing borders, but no clear-cut invasion. And this is actually a myepithelial tumor with these tubular structures, and you can even see cells embedded within this stroma. So this was actually a pleomorphic adenoma, which was very cellular, having less of a stroma. Now, what this cell tells us, this case kind of moves us into the differential of tumors or lesions which show stroma with varying degree and amounts and basaloid cells. The top will be definitely the tumors you're going to see most common is the benign mixed tumor or pleomorphic adenoma, then adenoid cystic carcinoma, basal cell adenocarcinoma, and basal cell adenoma, and polymorphous adenocarcinoma, which is more common in the minor salivary gland. And those you can see on deep-seated radiologic guided FNAs. This is the benign mixed tumor. I'm not going to go through this slide because this is in the textbooks. You can see myepithelial cells and different structures of the myepithelial cells or different forms on cytology. What I do want to point out that this always helps me that stroma in the pleomorphic adenoma, whether cellular or not, surrounds most of the individual tumor cells. So this is is really a reproducible finding in most of these cases. Now, since this is the most common tumor, and I love Game of Thrones, so you can see the Hall of Faces in the Game of Thrones. And I would say that there are many faces of benign mixed tumor. And this is, I sometimes believe, can be a biggest problem in salivary gland FNA, is to differentiate a BMT from other tumors. The classic BMT on radiology, and this is good to have this knowledge, is lobated, hypoechoic because it can be cellular, and has very clear margins. It does not show any invasive growth. You can see this beautiful troll hair appearance of the stroma. Look at the stroma surrounding each individual tumor cells. And depending upon the components, you may also see cartilaginous stuff. But on thin prep, this background may be much less or almost zero. What you do notice, which is very important to really focus on these groups, you will see stroma kind of surrounding each tumor cells and percolating among them. So this is where a differential of putting the benign lesions on the top of your differential may be very helpful. This is benign mixed tumor, not even is confined to the parotid, but you can also see it in deep throated locations. And this is a beautiful case, classic case of a benign mixed tumor, which has this gorgeous troll hair appearance of the stroma. And you really feel very intelligent when on the first day of fellowship to the resident or trainees, you say, oh, this is nothing but pleomorphic adenoma. And they always think that you really know a lot, but this is a very common tumor, and this can be easily diagnosed on FNA. So what are the variations on a classic BMT? I love superheroes, and this is like actually one of my favorite slides that I use, and I borrowed it from Vector Stock. So benign mixed tumor can also go under cystic change, and they can pose some diagnostic problems. Because that cystic change in a benign mixed tumor will give rise to a background which will appear very mucinous. But if you look at the cells, they are very plasmacytoid. They have very even chromatin pattern, maybe a mild nuclear enlargement, but again, you see the stroma following the cells. That is a very important finding in these cases. And this is a thin prep from the same case, and look at these spindle cells as well as some of the oval shapes. So this is very typical example of a cystic BMT, which can be, the background stroma can be very fluid-like and can be mistaken for mucin. This is the search path from this case, and as you can see, beautiful correlation of those spindle cells and this kind of a watery-looking stroma that we saw on the smears and on the thin prep. Now, some of the cellular BMTs may be nothing but all cells. Now, those are the cases that you are going to be putting it into more of a subcategory or salivary gland neoplasm of uncertain malignant potential. But on a thin prep, and these are thin prep slides, always look carefully for the stroma, and the stroma stringiness does remember that, because it does remain even on this thin prep. You're not going to see it in the background, but it will be along with it. So it will keep in company with the lesional cells. And here is another example. Also remember that the myoepithelial cells have beautiful intranuclear inclusion. So whenever you see an intranuclear inclusion in a plasmacytoid looking cell, remember you are dealing with a myoepithelial lesion. So the cellular BMTs can have areas on the search path which can mimic adenoid cystic carcinoma. So this is, remember, this is a heterogeneous tumor. So how do you present the biopsy? What do you think about the biopsying a heterogeneous tumor? That means when you're biopsying, you really have to biopsy or target multiple areas within this tumor to get really a view of the stroma, its association with the cells, and this monotony of the cells and kind of myoepithelial appearance. Because if you can imagine the needle stays only in this area, it will be mistaken for an adenoid cystic carcinoma. So these are the cases, again, which will be classified as a sum. Now, some other pleomorphic adenomas can have extensive squamous and lipomatous metaplasia, as well as sebaceous metaplasia. And these will give rise to squamous cells or this fat kind of embedded within the myoepithelial cells. But you can see on search path, again, these are circumscribed tumors, and this metaplasia can be of varying degree. You may not even see the metaplastic components on the FNA, but be aware that sometimes you can see squamous cells or clearoid cells mimicking sebaceous cells on FNA. So this can also happen in BMTs. Now, what about pleomorphic adenomas with atypical nuclei? And I think this is similar to what you see in schwannomas, which is called the ancient change. You see this really marked nuclear pleomorphism, which tends to be only focal in these cases. So if we look at the atypia, this is one of the cases in which this was a 55-year-old woman who had a painless parotid mass, which was present for 10 years. So that is very important. There was not a sudden enlargement history. And as you can see on this diff-quick, these cells are plasmacytoid, but the nuclei are enlarged as compared to some of these other cells. The stroma has that troll hair appearance. It is surrounding every single cell. But again, on this is a thin prep preparation. This is again diff-quick. This atypia really looks atypical. These are very pleomorphic nuclei. And again, nowadays, these will be classified in the sum with a differential diagnosis. When this case came out, this is definitely a benign mixed tumor, but you can see this focal atypia within this tumor. So that's what, again, I get to the point when you're biopsying these tumors, you really have to biopsy multiple areas to get a view of what you're looking at. Now, when we're talking about atypia, this is another case which the patient had a 5.0 centimeter parotid mass in a 60-year-old, present for 11 years, and now it is rapidly enlarging, and the ultrasound shows solid and cystic mass. That means that it is a complex mass. Little bit of a stroma, looks like a stroma, but you see this atypia is more multifocal. It's much more of a diffuse atypia than that single or double or two cell atypia. So that has to be kind of respected and taken into account. And when you look at this, you are beginning to see more atypical cells, little stroma in the background. Now, these are the cases which really you need to be aware of, because kind of history also shows you that there is a sudden and rapid enlargement of this mass. This is the thin prep slide, and you can see this definitely looks bad. So this is either suspicious for malignancy or it is malignant. Now, when this case came out, it was called as SUMP, and the differential did include carcinoma ex pleomorphic adenoma. And as you can see, the core of this lesion, central part of this lesion, is a pleomorphic adenoma, but then there is a high-grade or salivary duct carcinoma with comedonecrosis arising from that. So that form of atypia, which is focal, which can be just a reactive or that ancient change within the pleomorphic adenoma, versus that multifocal or diffuse atypia, which I think is more indicative of a associated malignant process. So when I'm talking about the pleomorphic adenoma mimicking basaloid tumors, and these are the tumors you're going to be classifying under some category, as I said, is really also dependent upon, one of the factors is how good this tumor is sampled, because I think these are very heterogeneous tumors. Now, the case I showed you, I think, is a classic example of it. This is a cellular pleomorphic adenoma, which has these core type of formations, and it is very, very cellular. And this is the tumor which will be a perfect example that will mimic a basaloid neoplasm. As I showed you, in some cases of pleomorphic adenomas, you can have these beautiful tubular structures which may show basement membrane type material, and they can mimic adenoid cystic carcinoma. And these are the tumors that you will be putting into some category. Now, how to handle these tumors? That means before you outright call them malignant. If you are thinking of a pleomorphic adenoma, because some of these areas look like pleomorphic adenomas, what I always do is to look for spindle-shaped cells or plasmacytoid cells, which is the myopithelial differentiation. Also look for classic features of pleomorphic adenomas present on the other areas of the slide. And I also process the entire specimen, because to me that is very helpful. And in some cases, the cell block may also prove to be helpful if you want to exclude adenoid cystic carcinoma or the other tumors by doing either FISH or immunostains. Adenoid cystic carcinoma, comes into the differential of these cellular basaloid tumors. We know what it shows. It does show this acellular hyaline matrix globules, and cellular atypia, which is actually not frequent. These aspirates appear more monotonous, almost more benign-looking basaloid cells from adenoid cystic than from a malignant tumor. The history always tells you in the textbooks that these tumors can be painful, but I have seen more painless cases than painful cases of adenoid cystic carcinomas, because I think they can be picked up smaller lesions because of their screening techniques. On a classic case of adenoid cystic, the ultrasound always shows these invasive borders. They tend to have infiltrative margins, and they are hypoechoic. So that will give you a very suspicious ultrasound features. And it's good to know this radiology because you can really kind of explain your cytologic findings in light of these radiologic findings, which is very important because nothing can be practiced in silo. So this is a classic case, really punched out, good, which I'll call as colloid-like basement membrane material, no cells embedded within that stroma or basement membrane, and the monotonous basaloid cells surrounding it. And on histology, you can really correlate where these cells are coming from. Be aware of adenoid cystic carcinomas on thin prep. And thin prep, that beautiful basement membrane material either gets lost or it stains very lightly. But you can again outline these really round structures, and you can actually, even on thin prep, focus up and down. And you can see how these structures kind of very lightly staining, almost transparent. That's the basement membrane material sitting and surrounded by these monotonous appearing basaloid cells. You may see structures like this, which almost looks like a follicular acinar structure, where you can assume that there was something in the middle which has fallen off. So that is very common presentation on the thin prep specimens. And then you can see in this case, the follow-up was adenoid cystic carcinoma. Now, there are cases on thin prep preparations where the stroma that basement membrane material, which is punched out and round, may be devoid of the cells, but may be seen in the background. So again, the notion that you're looking at the cells and you're looking at the background. And this even matters in thin prep preparations. So look for those punched out kind of basement membrane, really sharp globules of basement membrane material or matrix kind of stroma sitting out away from the cells. So here are the cells, and you can imagine an empty space that was there that was filled by this material. So you do need to correlate and look for those for that stuff. Now, this case was called as adenoid cystic, and the follow-up was adenoid cystic, and you can see the basaloid cells and those beautiful structures here as I seen in the thin prep. So it's good to, even if you think you are proficient in reading these FNAs, to go back and forth and really correlate. Because when we think of ourselves an expert, you're going to make the mistake second day and really will teach you a lesson. So it's good to keep on correlating because it's always very, very helpful. So when you have a diagnostic scenario of a basaloid cell-rich specimen of a salivary gland, these are your differentials that you will include. Now, my good friend, Dr. Facquin, told me once that if something is not typical, make sure you do not force a diagnosis on it. And he was 110% correct. So whenever it's something that I feel that I'm forcing into a Wharton or a pleomorphic adenoma, I back off. And most of the time, I will tell you, it turns out to be something other than pleomorphic adenoma, or sometimes a cellular pleomorphic adenoma or pleomorphic adenoma with really weird architecture or cells. I apologize for using the word weird, but we are all friends. Now, so this is a flow chart I follow, and this is also in the Milan system book, and we can add more tumors to it. When I think of the stroma, I look at the characteristic of stroma. Is it fibrillary? Is it hyaline? Is it mixed and other types? Or there is a scant to none? And based upon that, you can add and subtract different lesions to it. And this should be included in your differentials because the clinicians really like that differential. And it kind of helps them to really have what conversations they are going to have with their patient, because the Milan system is about conversation with the patient and the management of those patients with salivary gland lesions. So question number 4. So this was a 45-year-old woman who underwent ultrasonic biopsy of a 2.0 centimeter solid and painless parotid mass. This specimen will be classified according to MSRGC, and this is the diff-quick slide, and I'm going to show you the PAP slide here. Look at it and see what kind of cells are there and what kind of architecture there is. Can we open the poll, Joanne?
It looks like we have the poll open, and the options are sump, neoplasm benign, suspicious for malignancy, and malignant.
So I absolutely agree with you guys. This will be classified as sump because there's a monogenous population of the basal white cells. And some of you may say, well, there's all these cells, but it is very cohesive. That's why it is more of a benign process than single cells. This was my case. Even there were sharp borders. There was a basement membrane kind of material on the end, which is very typical for basal cell adenomas. I was kind of a little shocked with these open spaces, and I've been burned before. I called it sump, and it turned out to be a basal cell adenoma. So this is, some of you called it benign, you're right, but I think I personally I'm a wimp. I call this sump because to me, I have seen cases of adenoid cystic carcinoma looking like this, or basal cell adenocarcinoma rarely. So now let's start with this case. This is a 26-year-old man. We're going to switch a little bit of a gear with a 2.8 centimeter ill-defined mass bridging superficial and deep lobes of parotid. So this is what the case showed. The background had really a very kind of a thick appearance, and it does not appear watery or fibrillary. It almost has this paste-like quality to it. And there are cells, and if you look at the cells do have cytoplasm. Dr. Gupta always used to tell me the low-power diagnosis of cytology is as good as your high-power diagnosis. So don't listen to the people who will tell you to go to 100 or 60 all the time to make a cytology diagnosis. So that kind of stuck in my head. And I think it's very important. I'm sure all of you know this. So if you look at the background, it is kind of has this pasty quality to it. It's very smooth. There's no inflammatory cells. It's not fibrillary. And if you look at the cells, some of the cells do have cytoplasm, and I can actually even make out some of these columnar appearing cells here. On high power, some of the cells do have this squamoid and intermediate cell-like appearance, sharp borders, that again, this mucinous frothy material in the background. And this is actually the thin prep slide, which was very helpful to me. And I think thin prep can be very helpful in diagnosing some of these salivary gland lesions. And if you are in a practice where you only get thin prep, it's a learning curve, but I think you all get there, because if I can do it, you all can do it. And you can see here beautiful columnar-looking cells with the basally located nuclei. So they are trying to have this gland-like formation. And some of these cells even have like a little pinkish hue to the cytoplasm. So you get this picture of a kind of a mucinous material. And here again, you see these beautiful glandular or columnar-looking cells. So there's just some goblet-looking cells. And based on this was called as mucoepidermoid carcinoma. Now, this came out, and this was a low-grade mucoepidermoid, and you see those similar cells and that kind of a mucinous background here. So this really, really correlates. And even these cases, which are so easy to diagnose, by correlation, you will learn so much. You'll recognize that one feature that you miss, that it will make you really to look for this for the next time. So I know I'm preaching to the choir, but I think it's very important to understand that. Now, what does the textbooks tell you? You have this background, you can get those foamy-looking cells, which is very important, because those foamy-looking cells you can also see in benign cystic lesions. You see gland formation with beautiful mucinous vacuole or goblet-looking cells, intermediate cells, and as on, this really correlates to what you see on histology. In most cases of low-grade mucoep, because those can be sometimes difficult to diagnose based upon the cystic components. Now, These tumors that I call fail to read the atlas is the tumors which are less cellular. Again, look at the background. This is pasty, very thick material. It almost reminds me of, and I don't want to insult anybody from a pancreas cytology expert. This almost reminds me of a mucin from an IPMN. It's very thick. It really spreads out and kind of carries and drags the cell with it. Again, you see these structures, and some of these tumors can have a little bit of an oncocytic or denser cytoplasm. But looking at the Pap stain slides and the thin prep, you recognize the beautiful kind of sebaceous, foamy-looking cells, glandular cells, and then you may also even see lymphoid structures in them. So having lymphoid cells in a case that you're calling mucoep really should not make you go away from that diagnosis, because this is common if the majority of the specimen is showing features of mucoepidermoid carcinoma. And this is the case. Here are those lymphoid structures in that tumor that you are also getting as almost like a follicle on the cytology, and the background mucin and those beautiful goblet-appearing cells. And as you can see, this case does have a lot of cystic component, and that's why you are getting very less or minimal cellularity specimen on this case. But when you see lymphocytes, and this is actually, I think, something to be really remind you of whenever you see a salivary gland FNA with lymphocytes, they are not always lymphoepithelial cyst or Wharton tumor or an intraparotid lymph nodes. You can see lymphocytes in both benign and malignant tumors of the parotid gland. Now, when you're looking at a low-grade mucoepidermoid carcinoma, your differential is going to range from the benign to malignant lesion. So you really have to keep that flow chart in your head. So most of these, or a good majority of these, may be called as sum, depending upon the quantity and what the quantitative as well as the qualitative features. You have good cells, are they showing those features? They are not meeting all 100%, then these cases can be suspicious or in the sum category. I really have not seen many cases of these, but whenever this comes, I found these very challenging, is the case of chronic cell adenitis, because clinically they present like tumors. And I even seen sometimes a surgical pathologist kind of sweating on these lesions of the chronic cell adenitis, which may mimic low-grade mucoaps. You do get very cohesive fragments, not many single cells in the background. You may get mucinous background, but really tends to be more watery. These cells appear mimic intermediate cells. You may see few lymphocytes. So the inflammatory component may not always be there, maybe because of the sampling, or this has been a long-standing process. And this is actually one of the cases that I actually end up giving a differential. And as you can see here, these beautiful foamy-looking cells and the kind of mucinous-like material, I did retrospectively did realize that there were all these kind of lymphocytes which appeared as tangles in the background, which I kind of missed. And this case I ended up giving as a differential. And as you can see here there are some lymphocytes. And whenever I show this case around, when I was doing my first or second year of as a faculty, some people actually called it atypical cell suspicious for mucoepidermoid. I called it atypical and gave a differential, and I did include a low-grade mucoepidermoid carcinoma on the differential. The mistake I made was did a mucicarmin stain on a smear, and the mucicarmin was positive. So you can see mucicarmin positivity even in some cases of Wharton's, which has to be taken with a grain of salt, or even in chronic cell adenitis. So be aware of really going beyond the morphology and just throwing some stains to make a diagnosis, because it may, in some cases, lead you to a wrong path. And this case did undergo surgical excision, and this was a chronic cell adenitis, which can have squamous metaplasia. You can see mucinous cells. You may or may not get enough inflammatory cells to gear your diagnosis towards more of a benign process. So you really have to keep those things in mind. There are cystic lesions in the neck, which may mimic mucoepidermoid carcinoma. And this is actually a submental mass, which is a mucous cyst. The radiology is perfect for them. A person who is proficient in reading head and neck ultrasound, we'll look at it and we'll say, this looks like a benign cyst, which is either a ranula within the mouth or some kind of a mucous cyst. This does not look like a tumor. But look at the cytology of it. Mucinous, foamy-looking cells, and some of the cells, I can even tell you that these are glandular cells. So some of these benign cysts with the mucinous type material or even mucin in them can mimic mucoepidermoid carcinoma or low-grade mucoepidermoid carcinoma on the cytology. If I don't see all the components, like the good representation of intermediate cells, good representation of goblet cells, columnar cells, I will put this in the atypical category of Milan system. Be aware that some of these mucoepidermoid carcinomas can have mucinous oncocytic cells as well as mucinous cells. You may rarely encounter mucinous cells in a Warthin tumor. I'm still very careful because these cases are the ones that I really get more material to do FISH for mammal tube, which is available in-house. And sometimes we even do it in SearchPath to make sure we're missing an oncocytic mucoepidermoid carcinoma. So when you're looking at tumors, which are showing this mucinous and cystic background and may show oncocytic features, your differential is going to be a little different. You go based upon what you see in the background, it's going to either go from benign to malignant cases, and you look at the cytoplasm, whether it's granular, it's dense, or it is foamy, and what type of nuclear atypia you have. So these are the possible differentials, and I bet there are more that you will think of that can be included in the differential. I think this is, again, very helpful for the clinicians. So let's go to question number 5, and this is the fun question. In which year the cytotechnologists were voted onto the ASC Executive Board? Let's see how much you know about your society. Joanne, can we open the poll?
Right, looks like the poll's open. And the options are 1999, 1994, 2001, and 1981. And just as a comment, for those of you who are thinking, where are these from? You might want to visit cytopathology.org to learn more about the ASC. Okay, I guess we can close the poll.
Okay. Okay, the poll is closed. Let's move to the answer. And it was actually, this is the description. It was in 1995. The membership category was changed to cytotechnologist members, and they were allowed to vote, and they were also were in the executive board. In 1981, a new category was established, setting criteria for voting cytotechnologists in the society. That same year, 3 cytotechnologists voted onto the. So great milestone for our society. So now let's switch gears. Let's look at the tumors, which show foamy cytoplasm and kind of have little this oncocytic quality. This is a slow-growing, bright parotid mass, 50-year-old, which is present for which is been present for years, 5.0 centimeter, but it is slow-growing. It's not a rapid growth, not causing any paresthesias or any pain, or it's painful, it's painless, and not causing any problems. So that kind of leads you into a tumors which are either low-risk malignant neoplasms or benign, which are growing very slowly. So dealing with a low-risk malignancy or tumor. Here you can see these cells have beautiful, this foamy granular cytoplasm, and is the fried egg appearance. They have a lot of cytoplasm around them, and here's the yolk. Here is the, I don't like eggs, so I'm glad I can really kind of correlate a lot of these cytologic findings with it, hell with it. But you can see this beautiful honeycombing of fried egg appearance even on thin prep. And most of these groups are connected together. You do see some of these naked nuclei in the background. That means the cytoplasm is very delicate. This is a very classic example of a actinic cell carcinoma, and you will classify it in the malignant category of the Milan system. In this case, when it comes out, you can really correlate. And actinic cell carcinoma is one of the cases that I always run back and forth and correlate, because to me, this tumor can also be very heterogeneous in its morphology. Most of these tumors show minimal irregularity on the ultrasound, depending upon how big they are, but they can be really picked up on plain CT as well as on contrast. They really are regular, they're defined, they're homogeneous lesions. That means one cellular type. They really do not have much of a cystic, but actinic cell carcinomas can be cystic, and they can actually give rise to beautiful papillary formations on cytology FNAs. Now, this is another example of actinic cell carcinoma, and you can see how beautifully interconnected all these tumor cells are. They are trying to recapitulate that grape-like clusters with granular cytoplasm, with prominent nucleoli, and these interconnecting transgressing vessels in this, which has been beautifully described by authors of the Milan system book and other experts in the field. Again, look at this fried egg appearance of the cells, which I always look for because this always kind of holds me true. And you can actually even on the thin prep. So these all four are from the thin prep, from 4 different cases, showing you different morphologies that you can see in actinic cell carcinomas. Now, when you think about this, really what comes in the differential, and I'll tell you, I have even seen some of the experts make this kind of mistake, is to mistaken the benign acinar cells. And it also depends upon how you're smearing the slide. If you're really too aggressive in smearings, you may have the acinar cells fall apart and give rise to nuclei in the background, mimicking acinar cell carcinomas. So cases here, look for these structure, look for ducts, look for how together they are, look for the definition, and you will know that this, what you're dealing with, is not a neoplastic process. Is actually maybe the neoplastic process may be actually missed, but you can see the correlation that some of these cases, how they will be missed. So when you talk about carcinoma, there are tumors with the granular cytoplasm, clear or vacuolated cytoplasm, and the granular cell cytoplasm with lymphocytes come into. And actually the top of the list will be the Wharton tumor. You're going to see a lot of these tumors because Wharton tumor has oncocytes, which light up on the PET and the technetium-99 scan. And that's why they are picked up on the screening process of patients with other cancers in the body or other. So this is something very important to know. And you will see lymphocytes and oncocytes, lymphocytes in the background, plus percolating among the tumor cells. These beautiful oncocytes, you do get this, what is known as the mobile oil consistency in the background. Lymphocytes, look for lymphocyte tangles because that is a proof of lymphocytes. And sometimes you can get beautiful papillary fragments with the lymphocytes in the core of the papillae or attached to it, which really brings back the diagnosis of Wharton tumor. This is another case of Wharton, and there's actually a cell block which is showing you this really nicely bilayered epithelium here. So here's the oncocytes, and you can see the lymphocyte tangles with the core. So that's a classic example of Wharton tumor. Now, when you speak of oncocytes, if you do not have lymphocytes, then your differential moves away from Wharton's tumor. You're going to add an oncocytic neoplasm. Plus, you have to be aware of also what is known as secretory carcinoma or mammary analog secretory carcinoma of the salivary gland. So this is actually an example of an oncocytoma. So this is an oncocytic lesion, no lymphocytes. You may or may not include Wharton's in your differential because sometimes you may see less lymphocytes in an Wharton tumor also, but you are going to include an oncocytic neoplasm, including actinic cell as well as an oncocytoma in your differential. And this was actually an oncocytoma, but these are pretty rare neoplasms that you will see, but notice that really there are no lymphocytes, and that's when you will add this to your differential. What about these oncocytic or mixed clear cell cytoplasm lesions, which are showing marked nuclear pleomorphism? And this is where the other came into the play. This is a case of a 45-year-old man, and look at the beautiful vacuolation in the cytoplasm. Look at the nuclear pleomorphism, that density or granular cytoplasm plus vacuolated. So it does have a secretory appearance, and this is definitely, by definition, it's a malignant tumor. Now, these are the cases. I think it's important that if you have a good cell block and you're doing immunos, and if you have FISH available to do FISH, because these are malignant tumors which can metastasize, which can reoccur. And I've seen these cases come back and back in the patients with multiple recurrences. So if we always do, when we have secretory carcinoma in the differential, the FISH for it, and it's really helpful if you have it available. If you do not, if you have a cell block, do the appropriate stains, which is S100, mammoglobin, and other stains to exclude the possibility of an actinic cell like DOG1 or the other tumors which kind of go into this category. Now, this was actually a recent case, which was a 71-year-old, and this was actually almost like a 1 centimeter or less mass in the submandibular gland. Definitely on cytology, it has these features of a actinic cell looking carcinoma, right? But not many single cells in the background, but the pleomorphism in some of these cells, and really that appearance of a fried egg appearance was not there. Now, this is the case that if I'm calling it, I may be kind of hesitant to call it outright malignant. To me, it's atypical enough, but is it atypical enough to be called as malignant? And you're again dealing with a very small tumor. So I got a cell block and did stains on it. And as you can see, this is P63 positive. DOG1 was basically negative. It is music-Harman positive, and some of you may say there's just focally DOG1 positive, and this was the CK56. So strongly P63 positive, CK56 positive, music-Harman positive. And this is a case that I also did a mammal to FISH, and which was positive, and this was actually DOG1 negative on the search path. So this was actually a mucoepidermoid carcinoma, which showed this typical mammal FISH too. So if you have FISH available, take advantage of it because it can be done on cell block as well as on the smears in these cases. However, there was a poster, and I'm still waiting for the paper. Most likely it is out, where there were some tumors which had this muco-SNR differentiations, which were Dr. Faquin, Dr. Sitala, and Bishop were on that poster. I think it was 2 years ago at ASCAP. So question number 6, and that's the last question. This is a 65-year-old man who underwent ultrasound-guided FNA of a 4.0 centimeter cystic and solid right parotid gland mass, and this case will be classified. Look at what you're looking at, and look at the shape of the cells. Do you see viable cells or not? And this is another 3 pictures, and we actually even had a good block. Joanne, can we open the poll, please?
Okay, seems like the poll is open. And the options are suspicious for malignancy, sump, neoplasm benign, and malignant.
Okay, so I just want to spend 2 seconds on this. So if we go back, what you're looking at here is some keratinization. So there is some squamous differentiation. You're looking at some dyskeratotic cells, maybe a mitosis. But what is important to look is there is tumor type necrosis, which I call as a clinging necrosis. So these cells are still keeping their shape. They have a foamy cytoplasm, but look at these nuclei. These are degenerating tumor cells and not really macrophages. This clinging necrosis, and this necrosis which keeps its shape like an island-shaped type structures, is very typical of squamous cell carcinomas or tumors with squamous differentiation. And here you can see beautiful, almost like a tadpole-shaped cells. This was a pap smear that we called as squamous cell carcinoma, or at least suspicious. What I do want to point out that here in this case, there is this kind of a sebaceous type differentiation, and there is a squamous cell. So this was actually a mucoepidermoid carcinoma. So for me, this case can be outright called as malignant, but if you chose suspicious, then that is fine also in this case. So this was a good exercise. So let's just spend a couple of minutes on the specialist stains and immunostains. If you have it available, do it. Otherwise, you can base your diagnosis on morphology. But at this time, there is this expanding list of immunostains that, and I think this is still, this list, what I'm showing you is limited. My plea to you is that whenever you are applying an immunostain in cytology, please validate it in cytology specimens. Because those immunostains are not, they are not gospel. They're not 100%. You have to be morphologically suspicious or close to malignant to make these, or at least in the some category to do these immunostains. You have to have a Hep T cell block. If you're using one of the other cytology preparations like cytospins or smears, make sure you really have to be very cautious in interpreting these stains. Keratins is not a problem, but when you're dealing with mammoglobin, androgen receptor, DOG1, or even SOX10, you have to be a little careful because you may get spurious results. So there's the list of immunostains. But what I really think, which really helps us in majority of these cases, is the fish. If you have fish available, you can do it on the cell block. You can also do it on the alcohol fix, and sometimes even on the DIF-Quick or air-dried smears. And these fish, as long as they're validated, they will give you the exact answer, and they will be very, very helpful. I always find mammal-2 as well as the ETV6 for secretory carcinoma to be very helpful. And this is really an expanding list. It keeps on going. There's going to be more and more as long as you validate on cytology, I think. And this is going to be the norm because cytology specimens are becoming more and more common, especially from the head and neck, because then the patients can go directly to the surgery without having a core biopsy or biopsy done. So what are my 2 cents? And this is my summary slides. I think what I look at is you have to take everything in account, which includes the clinical history. Make yourself kind of familiar with some of the radiologic features. If the radiologist is, your practice does not allow you to be in conversation with the radiologist, at least if you have the radiology report available, ultrasound report, look at it, see what kind of process it is. Architecture really matters. Then look at everything, which means cellular background and the elements that you're seeing. Now, if you cannot pigeonhole something into a definite category, like pleomorphic adenoma, Wharton, actinic cell, it is okay to call it SUMP or neoplasm and give your differential, because it's better to do that than make a wrong diagnosis leading to totally a bad management paradigm. So this is my grouping is that based on architectural pattern, and this is in the Milan book also, you can really, looking at the radiologic findings and on your cytology picture, you can really group these tumors accordingly. There's definitely an overlap between this, which is unavoidable because of the nature of these lesions. But you can actually narrow your differentials, which will be helpful for the clinician of which type of surgery it is. And then you can also group them based upon cellular elements. And these are the 3 most common ones that you are going to notice in cytology, which is the basaloid, oncocytic or oncocytoid, and the clear cell features. And again, as I say, these can overlap. So you can really narrow your differential based upon this. So this is my version of how I think of these, where these tumors really overlap among each other. So you have a classic cases, and then you have cases which cross the boundary into more of these SUMP and categories. And we are talking about tumors. We're not talking about atypical FNAs. And the cases which will be definitely suspicious for malignancy or malignant. And this is the Milan system. These are really kudos to Dr. Faquin and Dr. Rossi and ASC and IAC, who really contributed so much. And this was an amazing exercise to go through to really learn more about these lesions and how to report them. We have been using Milan since past 2 years, and our reports are even formatted accordingly, and our clinicians love it. And sometimes I really get very happy when the clinician sends the report to us and say, how you will characterize this according to the Milan system. So that is really the success of this, what I really love. Do want to pitch in that, this is the time to really take a moment and look at all these beautiful things that surround us, because I think it is so important to take a note of this, because life is short, and these current times have told us we are, as a human beings, we are also very delicate. And so recognizing those beautiful things on your way, this is my shots from iPhone that I take on walking to the work. And when I get home, these are my cats, Kajal, and this is Jyoti. which really lights up my day. And so I'm a cat person, registrar. And this is really around the University of Pennsylvania that I walk. And this is actually a mural, which is within a half a block on my street. So when you come to Philadelphia, I ask you if you have time to take a mural tour of Philadelphia. And it's a guided tour of these beautiful murals throughout Philadelphia. So there are many beautiful things. And cytology is beautiful. So you know what the really pretty colors look like under the microscope and in your life. So thank you so much for giving me this time, ASC, and Dr. Barkan for inviting me. And thank you all for listening.
Thank you very much for the excellent pointers. And I love your message, stop and smell the roses. That is true for all of us. Yeah, maybe when I come to Philadelphia, I'll ask you to give me the mural tour. I like that idea.
Yeah. So the handout has also been posted. I see that.
Well, let's see. Let me remind everyone two things. Thing number one. So if you haven't seen already, the handouts is under the hand tab in your control panel, typically on the right on the screen. So you may be able to download that. Also, if you've missed this or you want to listen to this again, this will be available on our YouTube channel, Cytopath 1951. So again, Cytopath 1951. So there are a couple of questions, and let me see if I can sort of ask them one by one. So the first question is atypia and the ancient change you talked about in pleomorphic adenoma. So you see these rare occasional atypical cells. First of all, what do you define as atypical in the Milan system? And secondly, if you see these and you know that they're ancient change, do you still call them atypical or do you call them benign? How do you look at these?
So first, let me answer the atypical question first. So if I see atypical cells in a background of something which looks classic, to be honest, personally, I have put them into the SUMP category because the atypical category to me, it's if the background is neoplastic, then it moves into the neo, and I will classify them as SUMP. And then I will say there are atypical cells, and they may be focal atypia in a benign neoplasm like pleomorphic adenoma or Warthin's, and blah, 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 and include all the rest of this stuff. But I cannot exclude the possibility of a higher grade lesion arising in the background of a neoplasm. Now, a case which is a step down from neoplasm, which has most of it is reactive change, and what you're looking at is few atypical cells. If you happen to be on site and you are dealing with, you know that the needle was in the lesion on the ultrasound, and I'm talking about radiologic guided FNAs, then you can say that there is atypical cells. You definitely are going to classify this in atypia, but I favor this to be more of an extreme of reactive and reparative atypia because most of the lesion is showing inflammatory processes. If I am on site, I ask for extra passes because the more I see, the better it is. And sometimes I end up seeing granulomas and other things, and then I can really put it into a non-neoplastic category. I really don't pigeonhole my diagnosis based on majority into these categories, either category like non-neoplastic, even if I have atypical cells, because I really do not have the guts to really not take in account, because as we know, you can have inflammatory infiltrates around tumors also. So this is how I categorize it. And I think that's why I find Milan system to be very helpful, because if in the past, I would have called these atypical and given a big differential, the clinicians always looked at me funny because they said, you're calling everything atypical. So I think this is how I deal with atypical cells. I gauge myself whether I'm already in the neoplasm category or I'm hanging between the non-neoplastic or neoplasm category.
Okay, so something along the lines of that. So when do you call something a straightforward PA? Say it's a cellular PA versus you're thinking, is it a other basaloid lesion? What is the line between PA versus SUMP for you?
So, I mean, I think that's very personalized. It depends from case to case. As I have a good representation of what I can call as myoepithelial cells. So remember even the pleomorphic adenomas that mimic the group of tumors that are mimicking basaloid tumors, if you go back and look at that, granted you have processed the entire specimen, you are going to see spindle cells, you're going to see some form of stroma, and this is where the diff-quick stain on-site rose smears are very helpful because you may lose that on thin prep only preparations. So if I see those, and these basaloid looking cells are kind of sprinkled in the midst of it, and I have a good representation of the stromal character material, either a lot of it or less of it, or very minimal embedded within the cells, I will call that as pleomorphic adenoma. But I have to gauge myself. And that gauging myself is that if I am kind of stuck, I will ask the lab, and I do that, and I will call them and say, do you have enough material to do a cell block, or do you have enough material to do another thin prep for me? And they're very good. Actually, I'm blessed with a great preparation of people and the cytotext, and they will even try to do sometimes a very small salient cell block for me, and that becomes very obvious for me to look at that. To be honest, I have never found doing immunos on a very limited cellularity cell block to say whether it's a pleomorphic adenoma or something else, because it kind of confuses me more. So I think it's case-by-case basis. It's about you're looking at every single slide, which we all do. I'm not saying you will not, and looking at all the elements. As long as it is equally carried through each of the preparations, then I'm comfortable to call it pleomorphic adenoma. And I'm talking about those cases which are kind of a little bit far away from what you see as a classic case.
Mm-hmm. So here's another question for you, and it's a tough one. If you can only afford to use one type of stain for FNA samples of the salivary gland, which one should it be?
Oh my God.
Pep stain. This is a Sophie's choice kind of question for you, and it's so unfair.
Who is it? No, okay. To be honest, you know what? When I was training, Dr. Gupta is, and I'm glad I trained under Dr. Gupta because he really valued the rows. He really valued how, and he will your hand if you made a bad smear, because he will say your preparations are as good as your diagnosis. If your diagnosis sucks, it's because your preparations suck. I mean, he always said that. If some of you know Dr. Gupta, he never minced words, and God bless him. It really made me learn, and that's how I learned. With somebody's stick in their hand. So, I really value the diff-quick because, pleomorphic adenoma being very common. And diff-quick is very good because it gives you a great, really makes you proficient in reading the background, the architecture. You can really make 95% to almost 100% diagnosis on the diff-quick. But as we were training, and I don't want to make this answer too long, as we were training trainees, one of the biggest complaints came about our program that we were not using thin prep. When they were going out in the real world, they were seeing only thin prep. And they really were having a lot of difficulty in diagnosing thyroid FNAs as well as salivary gland and head and neck FNAs. So I think I like all three, but I think when you're looking at the stroma, the background, and the cell size and its relationship, diff-quick is Romanovsky stain is great. Pap stain gives you great chromatin details, highlights intracellular mucin, cytoplasmic mucin, those beautiful fried egg appearance of the actinic cells. So I will tell you, if you give me a good Pap stain smear combined with a diff-quick stain smear, this is the political correct answer, I am happy. I will be able to diagnose 60% of the lesions that I see. I will say more or more on diff-quick only. But I will say that I don't have an exact answer, but I think the combination of the preparation is becoming very, very important if you're going into specifics, diagnosing specific lesions on salivary gland. So I'm sorry, I cannot answer this.
No, that's good. Like I told you, it's a Sophie's choice kind of question. It's very difficult. And to me, gosh, give me anything but just thin prep alone. Thin prep alone is quite a bit.
It is scary, but I think it's a learning curve, and that was one of the biggest hurdles we have to come through. And I don't want to take the names, but there are a few cytopathologists here, like Dr. Cindy McGrath, our director, who really was behind, kind of had my back, and we really pushed for thin prac, and even Dr. Gupta liked it, but he was not so fond of it. But we got it through because I think in the end, it really helped us because we were getting outside FNAs, which were just coming in as a thin prac. So this was like a big, long learning curve, you know.
Yes, yes. Now I have two other questions, and then we'll be. One question is, if you only see spindle cells, how do you categorize this as?
So that is very difficult. So I will tell you that I have made that mistake in the past. I have seen cases because you have spindle cell tumors in the salivary gland. You get schwannomas in the salivary gland, which can be mistaken for a salivary gland neoplasm. Usually patients will feel pain when you biopsy those, but they can be cystic also. So that can be problematic. When looking at the cytoplasmic characteristics and the cells, if I see that this truly looks like a mesenchymal tumor, or it is in the middle of it, and if I'm again into this category where I'm already in the neoplasm, I will call them neoplasm, and then I will put a long differential saying that this is, granted there's no cell block and stuff. I will say that, there are salivary gland tumors with this spindle cell morphology, and I've seen a couple of pleomorphic adenomas just giving rise to nothing but a spindle. Put those in the differential, but I will include other mesenchymal tumors. If I am sitting on this cusp of salivary gland neoplasm or a neoplasm versus something non-neoplastic like chronic salidinitis, because in those cases you can also get spindle cells, call it atypical, and then I will give a differential.
I see. Okay. All right.
I don't want to sound like a wimp, but I love different and really not. I don't pigeonhole those. So the bills, bills, those words of wisdom still remind me. So I am always careful.
I think that's be able to come up with differential diagnosis so that you can lead your clinicians appropriately, and not always the answer, and that's totally okay. So the last question comes from one of our participants, and they're asking, how do you differentiate between oncocytoma versus cell carcinoma?
Okay, so
this is morphological.
So this is the one that I always I think it's exciting field, as well as it's scary. So it's like really watching a very good horror movie. You get these oncocytic cells, and they look on diff-quick very oncocytic, and suddenly you start to see this clearoid, oncocytoid, kind of foamy-looking cytoplasm on the thin prep, as well as the pap stain slides. As long as the cells have a dense sharp cytoplasmic borders, and greater than 70% of the cell maintain that oncocytic appearance, my top differential will be an oncocytic neoplasm, which includes oncocytoma, because oncocytic carcinomas are very rare. I will include acinar cell carcinoma in the differential. Now, those are the cases I will beg my preparatory lab to give me a cell block. And remember that doing P63, CK56, S100 stain is really helpful in those cases, because some of these oncocytic tumors are usually not P63 positive. And that really helps you. If they're strongly antigen positive, then it will be helpful. DOG1 will be good for acinar cells. And you can actually even do DOG1 on a limited cellularity specimen. If I have to think about, if I'm going more in towards the malignant categories like actinic or secretory carcinoma, I will do a FISH. But if they appear oncocytic, so it looks like a duck and walk like a duck. If it's oncocytic cells, you tell yourself these are oncocytic cells, and you're applying those strict cytomorphologic criteria, then that most likely is going to turn out to be an oncocytoma or some form of Watson where there were very minimal amount of lymphocytes.
And just sort of for everybody's sake, for P63 and P40 are similarly used in terms of...
To be honest, somebody's going to slap me now, but I like P on salivary gland tumors than P40. So don't be angry with me. I know everybody has their favorite immunostains, but somehow I find P63 to be more robust. So I use that. And I'm going to be honest about it.
I love the honesty. That is so nice. Well, thank you so much for this excellent presentation. This was so fun to listen to and such good pointers. And yes, thank you for volunteering. And again, reminding everyone, same time next week, we're going to be listening to cell blocks and immunohistochemistry given by